federal insurance programs. We call on our South Carolina state lawmakers and governor to take an honest, impartial look at the opportunity to cover South Carolinians caught in this coverage gap with $790 million in enhanced grants offered under the new federal legislation. To date, 12 states, including South Carolina, have not expanded their Medicaid programs, leaving many adults uninsured. As you can imagine, being uninsured amid a deadly pandemic can have disastrous effects on people's health, especially those living with chronic health conditions. Many have lost employer-provided health insurance when they were laid off or their businesses failed last year. Our governor has repeatedly said that South Carolina cannot afford to expand Medicaid. Tonight, we will demonstrate why South Carolina cannot afford not to expand. This forum is sponsored by the Unitarian Church in Charleston, Circular Congregational Church, and the League of Women Voters, which presented two programs in January, Mind the Gap, which explained in detail how Medicaid operates and how hundreds of thousands have been caught in the gap between traditional Medicaid and the Affordable Care Act, unable to qualify for either because of technical eligibility rules. Tonight's keynote speaker, Sue Berkowitz, will discuss key provisions of the Rescue Act and how it would provide a win-win for our state. Medical insurance coverage for our citizens who lack and as a practical matter cannot obtain coverage, and an unprecedented cash infusion for our state that would cover the cost of expansion many times over. Sue leads the South Carolina Appleseed Legal Justice Center and has been following developments in healthcare, insurance advocacy efforts, and legislative developments that have brought us to this point in time. Also on our panel tonight will be Frank Knapp of the Small Business Chamber of Commerce and Dr. Graham Adams, CEO of the South Carolina Office of Rural Health, a statewide nonprofit organization striving to improve access to care, quality of life, and health outcomes in rural and underserved communities. First, a few ground rules. Please keep your microphones muted and your video feeds off during the presentation to help with presentation quality. Please do that now. Our speakers will have about 45 minutes in aggregate. To help them with time, our timekeeper will give them a wave when they need to wrap up and turn the microphone over to the next.
That's me, and you're not on. You're not in the picture.
We will disable the chat during the speakers' presentations to avoid distractions. If you have questions, please put them into the chat box when you can do so. We do plan for a 15-minute Q&A at the end, and our question monitor will read as many as time allows and direct them to the appropriate speakers for answers. We will be recording this program and will notify all of you how you can access it after tonight. We encourage you to send it to all your friends and colleagues. If you have not had a chance to fill out the survey yet, please do so. When you can, you may fill it out at the end of the forum. The link to that is in the chat box. It will help us stay in touch with you after the forum and capture how you might like to be involved in the future. We've also created an email address, medicaidsc@yahoo.com, that you can use to email questions or comments. A follow-up email will be sent with links to information discussed in this forum and the relevant links. Now, to tie tonight's program back to the Mind the Gap series that the League of Women Voters put on, I would like to introduce Dr. Elizabeth Brown, a volunteer with the League of Women Voters of the Charleston area. Dr. Brown is an assistant professor and health services researcher at the Medical University of South Carolina. Thank you, Dr. Brown, for being with us.
Good evening, everyone. I'm so thankful to be here tonight, not only to discuss the issues and the problems that we have in our state, but also to hear about the potential solutions to address these issues. So some of the things that we discussed in the League of Women Voters Mind the Gap series were the uninsured in South Carolina. So before we get to the solution, we need to know what exactly is the issue. So in South Carolina, according to Kaiser Family Foundation, we see that the majority of people who are uninsured are adults, male, or white, identify as white. About 15, almost 16% of working age adults, so we're talking about 18 to 64 years old in our state, lack health insurance. And to put a number on that, that's about 465,000, a little over 465,000 people right here in our state that we call home that do not have health insurance, 18 to 64 years old. And we might ask, well, why are these people uninsured? There's two general reasons why people are uninsured. Some choose not to get health insurance. They're younger, they're healthier, they feel as though health insurance is not for them. But we also have a group of people that cannot afford health insurance. They may be low income, self-employed, or small business owners or employees. So that's really going to be tonight's focus, focusing on those people who cannot afford health insurance and how we can get them that help. So this is an issue because we see in the literature, the research literature is when people do not have health insurance, they delay care. So we see those people having preventable hospitalizations and even deaths. And so when I say preventable hospitalizations, we're looking at people who delay care, not going to the primary care doctor, and they're ending up hospitalized for something like diabetes or hypertension, dehydration, even urinary tract infection. And you may ask, well, why would someone delay care? Well, when you don't have health insurance, the cost of going to see the doctor, some people cannot afford it. If you work hourly and you don't have sick leave or annual leave, transportation issues, living in rural areas, we tend to see a lot of our rural counties have higher percentages of people without health insurance. And physical distance to a provider's office, specialty care included, primary and specialty care. These types of things burden our hospital system. Our hospital systems are left with uncompensated care, meaning the person that has just received care cannot pay for the care. So, Richard, could you hit the next for me, the next tab? Thank you. So health insurance. We see also in the research literature that it increases the use of preventative services. So we're talking primary care. It improves health outcomes. So when states expand Medicaid or give health insurance to people, provide affordable quality health care to people, we're seeing them not only use the health care, but they're getting early screenings. They're getting illnesses diagnosed earlier, and they're detecting these illnesses and diagnosing them earlier. One that we've seen in the literature is cancer screenings. So earlier screenings, earlier detection, earlier diagnosis. Guess what, guys? It saves lives, having affordable health care insurance. So what we're really going to focus on tonight is those people who are uninsured, but then also recent health policy changes that could impact our state and help about 180 to about 200,000 South Carolinians get health insurance. And I don't think this figure actually includes those who lost their jobs due to COVID, who lost employment or had a decrease in hours. So potentially now they are low income. So that number may be a little bit higher. So I'm actually going to turn it over to Sue Berkowitz, but before I turn it over to her, I'm going to give a quick introduction. Sue Berkowitz is the director of the South Carolina Appleseed Legal Justice Center. The South Carolina Appleseed Legal Justice Center is a nonprofit organization that fights for working class South Carolinians to overcome social, economic, and legal injustices. Tonight, Sue will discuss provisions in the American Rescue Plan Act that could incentivize South Carolina to increase access to health insurance and health care. She will also provide strategies and actions that we can all take to influence our elected officials to accept the significant financial incentives contained in the new law, and finally, cover those who do not qualify or cannot afford health insurance. Thank you, Sue.
Thank you, Dr. Brown. I appreciate the introduction. And I also want to thank the UU of Charleston and the Circular Congregational Church and the League of Women Voters for holding this forum. It's very timely and very important. And I believe when I see the number of people who have signed on tonight that you, like myself, have been wanting and working on Medicaid expansion for almost a decade now. Because as we remember, that was part of the Affordable Care Act. And I do remember professionally, right after the Sebelius decision was read from the Supreme Court, and we found that the Affordable Care Act was in fact constitutional, I went back up to the State House to continue my work, feeling euphoric. And that came crashing down very fast, because I think 30 minutes or maybe a few more minutes and 30 minutes after the decision was announced, then Governor Haley and her Medicaid director, Tony Keck, got out their podiums and started to talk about how there was no way South Carolina was ever going to expand Medicaid, and started using rhetoric, calling it job killers and things like, the same things we had been hearing about the Affordable Care Act. But what was so upsetting upsetting because we weren't going to be expanding Medicaid, but I think what was so disappointing to me and upsetting was because this decision was made without ever doing an analysis or consideration what was best for the state of South Carolina. It was purely a knee-jerk reaction, and Medicaid expansion, the door was shut. Even though there were a number of legislators that would have been more than happy to consider it, they just weren't going to go against that political decision. And what's really important, as Dr. Brown talked about, is that Medicaid expansion would help address so many of the healthcare disparities we know we have seen in South Carolina over all these years and have been highlighted during the pandemic. The good news is that for those people who did lose their job and maybe went on unemployment, they can go into the marketplace and for the next year and get healthcare coverage through the marketplace for no cost. But that's not a long-term solution for many low-income workers. If I could get my first slide, I just want to explain how does Medicaid expansion work? Oh, wait, I guess no, I think what I will do is just explain that the Affordable Care Act allowed all states to expand Medicaid by providing the states with additional money. And for the first 3 years, it would be 100% to help cover. Are we not going to have slides? No? Okay. To help cover, that's technology. Oh, there we go. There we go. Okay. So the Affordable Care Act provides states with additional federal funding to expand Medicaid for adults under the age of 65, because once you're 65, you no longer can go into the exchange and you are eligible for Medicare, but up to 138% of poverty. Recognizing that people who were below 138% of poverty couldn't reach into their pockets to pay any kind of cost sharing for the Affordable Care Act. So what does 138% of poverty mean in 2021? For a single adult, that's $17,774, or for a family of three, which could be 2 adults and 1 child, or could be an adult with 2 children, would be just over $30,000 a year. So these are families or individuals who are not able to purchase with a subsidy in the marketplace under the ACA. So what ends up happening is, for most of these folks, they actually fall into a gap. So states that have expanded Medicaid, which is free or low cost healthcare coverage made available to people with incomes below that amount, they were able to help families who are not able to afford insurance, able to hold on to more financial resources because they didn't have to worry about paying out-of-pocket costs, and have better healthcare outcomes. And in fact, for states that did expand Medicaid, we know that their uninsured rate was substantially lower than those states that didn't expand. So can we go to the next slide? So the coverage gap, I apologize. Like I told you, I've been working on this for over 10 years. When we first started working on Medicaid expansion, the coverage gap was 194,000 people. Now it's about 188,000 people. They fall in that gap because they cannot go in to get the tax credits, and they're not eligible for Medicaid, because Medicaid has what we call categorical eligibility. And so for adults, and as you can see, from 0 to 62%, some adults are able to get Medicaid, and that's because they have children in their household. So very, very poor adults who are under 62% of poverty, and that's about $8,000 for a family of 3, those adults can get Medicaid. But any adult over that amount, up to 138%, cannot get Medicaid in South Carolina. Now, some between 100% and 138% could go into the marketplace, but often they don't have the resources, even for the small amount that they might need to access it. So who is eligible for Medicaid? Children at 208%, pregnant women at 197%, and adults. And while it says 62%, there's also there's a 5% bump on there, so it takes us up to 67%. But primarily, childless, non-disabled adults cannot access Medicaid. So the next slide. Next slide, please. Well, that's the 188,000. 188,000 South Carolinians who are in the healthcare coverage gap. The majority are folks who are working but low income. About 27,000 are in the military, or were in the military or veterans. About 63,000 are low income near elderly citizens who are between 50 and 64 who fall in that gap. And especially as we see people losing their jobs and not getting reemployed, I think we're going to see that increase. Okay, next slide. So how is Medicaid funded in South Carolina? It's a federal state program. And I always like to call South Carolina a donee state, because we actually have a pretty high match rate. And what does that mean? It means for every 30 cents we put up, we draw down 70 cents for your regular Medicaid beneficiary. For our children's health insurance program, we have an 80-20% match rate. Now, for Medicaid expansion, for the first 3 years, if we had expanded, we would have drawn down 100% of those dollars. 100% of coverage dollars would have been available to South Carolina, and was available to the 30 plus odd states plus the District of Columbia that took advantage of it. Now it is a 90-10 match. So that means for every 10 cents we put up, we draw down 90 cents. Now, I'm a lawyer, not a mathematician or a financial analyst. But if somebody said to me, for every dime you put up, I'm going to give you 90 cents, I would think that's a pretty good deal. But South Carolina didn't take that over the last 10 years. And about $11 billion got left up in Washington, D.C. Now, I will say we are a donee state because South Carolina actually sends less dollars up to Washington, D.C. to the federal government than we actually get draw down for all the programs that are given to us in our state. But despite that, we chose not to take that $11 billion to increase healthcare for the uninsured. Next slide. Well, that didn't work for us, but now we have the Recovery Act, and there's an incentive in that. As you know, we're already drawing down about $2 billion for a lot of different things that South Carolina needs. But for the 12 states that have refused to accept Medicaid expansion, not surprisingly, primarily in the South, I like to call us holdout states or non-expansion states, as we often refer to them. If we agree to provide expansion to our residents, we will receive an additional 5% bump to our federal match rate. Remember how you saw for all of our Medicaid beneficiaries, and there's about 1.2 million Medicaid beneficiaries in South Carolina. If we agree to expand Medicaid, we'll get that 90-10 match, but for all the others, we'll get a 5% increase, and we won't be getting 70 cents for every 30 we put up. We'll only have to put up 25 cents, and we'll draw down 75 cents. So what does that mean and that'll be for a 2-year period of time, if and when any of these states agree to do that. So during that 2-year period of time, if we agree to do that, we will draw down, according to Kaiser, and they're the organization. Kaiser is the expert group that we all listen to, and their data is impeccable. South Carolina would receive about $780 million additional federal dollars for our current Medicaid beneficiaries. And out of that, we would have to spend about $180 million to cover those additional people who are not insured right now. So that means for a lot of folks, for example, people who are not covered by Medicaid right now, who need to have mental health services through the Department of Mental Health, and right now are paid 100% with state dollars. If they went into the Medicaid expansion program, that means that money would not, their coverage would not be 100% state dollars anymore. It would be 90-10, and that money would be savings that the state of South Carolina would incur. So let's go to the next slide. Medicaid, so for low-income individuals and families, how would they benefit from this expansion? Because we know South Carolina would receive $780 million. We would also not have to spend all of our state dollars for some of the coverage that we provide to people, whether it's for mental health coverage or if it's for people who are incarcerated who then go into the hospital. No, I'm not done yet. The hospital, who we then have to pay for them 100%, they would then be covered by Medicaid expansion. But Medicaid coverage translates into financial flexibility for families and individuals, allowing lower income families to use their limited dollars to spend on basic needs. And if we didn't learn from the pandemic how much people are suffering because they have such limited dollars and don't have the ability to save and have a nest egg like some of us are so fortunate to have, if they did not have to spend money on health insurance or for out-of-pocket costs for health care, it would help them with their financial needs towards rent or utilities or food. Every dollar a family doesn't need to spend on out-of-pocket costs when one gets sick goes to all the other basic needs and other necessities of a family, and allows them not to run into the same kind of financial strains that we often see families run into when something happens, like loss of a job or an emergency need like a car being fixed. Medicaid expansion means more healthcare coverage for more people in our state. It's an expanded opportunity for both individual success and success of our state. Okay, my last slide. So Medicaid provides coverage for the poorest of the poor and disadvantaged Americans. Mostly it's providing, though, for those who are working and those who are trying to make ends meet. A federal and state partnership structure is an effective way to provide care and assistance to individuals who need it most. And that's why under the Recovery Act, the feds are recognizing that they can help states, especially the non-expansion states, by giving more money for their current Medicaid beneficiaries in order to help us with covering those who are not covering now. As is, Medicaid is one of the most effective ways of providing coverage for 1.2 million South Carolinians. The administrative costs are much lower than private insurance, and is what my dear friend Lynn Bailey, who is an economist, has always called it's the foundation for all of healthcare in our state. So if you want to keep informed about what's going to be going on over the next few months and probably the next few years, you can go to our website, www.scjustice.org, and sign up, and we'll make sure you get updates, or you can reach out to me directly. But we can't do this alone. And it's going to take all of us by contacting our legislators and letting them know that this is critical for the financial well-being of South Carolina and the health care of all those that we care about. So I'm going to turn this back over to Ren so that he can introduce the next speaker. So we have plenty of time for our speakers, and then we're able to take questions from everybody. So thank you so much for this opportunity.
Thank you, Sue. I would now like to ask Frank Knapp, who is the president and CEO of the South Carolina Small Business Chamber of Commerce, to describe what Medicaid expansion would mean for small businesses in South Carolina and how that would enhance the attractiveness of South Carolina for a business location. Frank co-founded the South Carolina Small Business Chamber in February of 2000. He serves as the president and CEO of the 5,000 plus member statewide advocacy organization that has taken a leadership role in making South Carolina more small business friendly in areas such as taxation, regulation, worker training, workers' compensation insurance, utility costs, health insurance, energy conservation, and economic development. Mr. Knapp serves on the advisory board for the South Carolina Small Business Development Center and was recognized by the Small Business Administration as the 2014 South Carolina Small Business Financing Advocate of the Year. From 2015 to 17, Mr. Knapp served on the U.S. Small Business Administration's Region 4 Regulatory Fairness Board, an advisory board to the SBA Office of the National Ombudsman. Frank, thanks for being here. We look forward to your comments.
Well, thank you very much. And thanks for the opportunity to be on the program this evening. I am Frank Knapp. I am president and CEO of the South Carolina Small Business Chamber of Commerce. We've been an advocate for health insurance reform almost since we began in 2000, because even back then, health insurance was just too costly. Now, I've been working with Sue on healthcare reform since 2005. When we held forums around the state, along with AARP and South Carolina Fair Share. We actually were successful in expanding Medicaid a few years later when we got the cigarette tax increase so that children and families with incomes up to 200% of the federal poverty level would be covered. After the Affordable Care Act passed, all of us were hopeful, as Sue said, on the Medicaid expansion front, until, of course, it was ruled that the states couldn't be forced to expand under the ACA. So we've been beating that drum ever since. In 2015, we made a big push to close the gap and even had funding for our website and advertising. Yet here we are today. The state has left about $11 billion, as Sue has said, on the table because it has not expanded and hundreds of thousands are still uninsured. But now we have a new incentive for the state to expand thanks to the American Rescue Plan. Our business reasons for expanding Medicaid are the same as they've always been. Healthier workers are more productive workers, and workers with health insurance are healthier. And who are these workers who would qualify for Medicaid if the state expanded? The U.S. Department of Labor back in 2012 tried to answer that question. Richard, would you please show this slide? Okay, well, maybe we're not going to see that slide. But anyways, let's, we'll just move on. Basically, this slide just showed that there are over 150 occupations where people who are working in jobs that have annual incomes below 138% of the poverty level for a family of three. So when you see anyone in these lines of work, there's a good chance that they are uninsured because of the refusal of the state to expand Medicaid.
There's your slide, Frank.
Okay, I think I'm done with it. You can take it down now. That's our first reason. The second reason is that the uncompensated care for the uninsured increases health insurance premiums for those who have insurance. Small business owners are paying more either for group health insurance or for their own family's health insurance. Third, hospitals are major employers in our rural areas, so when they close because they can't afford to stay open, because they have too many uninsured patients, those local economies suffer. All the small businesses in those communities suffer. And rural hospitals closing is not a good look when the state is trying to recruit manufacturing, especially if the state is trying to get that manufacturer to locate in a rural community. Fourth, all the money that would flow into our state from new federal Medicaid dollars goes right into our local economies. And that creates demand for the goods and services of our small businesses, and that creates jobs. Now, unfortunately, these business reasons haven't been successful in convincing our legislature and the governor to expand Medicaid for the past 11 years. But now we have this new financial incentive on the table for the legislature and the governor to consider. Plus, other red states have already led the way on this issue. They have either expanded Medicaid already or are seriously thinking about expanding because of the financial benefits to their state. With all of this, will all of it be good enough for South Carolina into debating at least expanding Medicaid? I don't know. However, the more that people like you who are on this call are involved in calling on the legislature and governor to expand, the likelihood does get better. But there's something else that state policymakers need to think about. South Carolina can either take the federal dollars to expand Medicaid, be in charge of how the program is administered, and get a very generous financial incentive. Or there's a good chance that the president and Congress will add a public option to the Affordable Care Act, which will automatically enroll anybody who would have qualified for Medicaid if we had expanded. In this latter scenario, the federal government will be in charge of expanded Medicaid program, not the state, and there will be no extra federal money for the state. We can be in charge, make the policy decisions, and get hundreds of millions of no strings attached federal funds. Or we can not be in control and lose all that federal money. Small businesses can live with either scenario, just so we get these uninsured covered. Thank you.
Thank you, Frank. I would now like to introduce Dr. Graham Adams. Dr. Adams serves as the CEO of the South Carolina Office of Rural Health. a statewide nonprofit organization striving to improve access to care, quality of life, and health outcomes in rural and underserved communities. Since joining the Office of Rural Health in 1995 and his appointment as CEO in 2002, Dr. Adams continues to provide technical assistance regarding strategic planning, grant development, funding opportunities, infrastructure development, and resource allocation. Dr. Adams?
Thank you, Ren, and thank you all for the opportunity to join you this evening, and got a few minutes. And I've been asked to talk specifically about rural hospitals and the rural healthcare infrastructure and some of the challenges that are really in place when you look at trying to provide care with a high uninsured population. So when you look at South Carolina, depending upon how you define rural, about 20% of our population is rural and about 80% of our land mass is rural. And hospitals, as we all know, in every community really tend to be kind of the cornerstone of the healthcare community in that county. When you look at small rural hospitals, these facilities struggle and have struggled for quite a long time. And that is for a variety of reasons. Insufficient and inadequate reimbursement from third-party payers. That is Medicaid, that is Medicare, that is a lot of Blue Cross and folks like that tend to pay less for rural encounters than they do for more urban healthcare visits. Aging infrastructure is certainly an issue in rural hospitals. Some of these facilities, some wings, some parts of the hospital are upwards of 70 years old at this point. And patients choosing to go elsewhere and just passing by that local facility. But one of the main reasons that a lot of these small rural hospitals struggle is because a high percentage of their patient base is uninsured. And research has shown that really does go towards their bottom line, and it affects their viability. So the Sheps Center at UNC is one of the groups nationally that tracks hospital closures and rural hospital closures. And if you look at their data, since 2005, about 180 rural hospitals have closed throughout the country. And in 2020, just last year, 20 rural hospitals closed, which is the most closures per year of any year since they started tracking the data in 2005. And the number of rural hospital closures has increased every year for the last 5 years. So you see this trend, it's occurring, and it tends to be happening more in the southeastern states. And it is no coincidence that these also happen to be states that, for the most part, did not expand Medicaid. So states like Alabama, Florida, Georgia, North Carolina, South Carolina, Tennessee, and Virginia account for almost a third of all of those 180 rural hospital closures since 2005. South Carolina has had 4 rural hospitals closed since 2012. Bamberg, Barnwell, Fairfield, and Marlborough counties have all had their hospitals closed. And we expect 2 additional small rural hospitals to close within the next 2 years. Williamsburg County Hospital and Lake City Community Hospital are planning to close and be replaced by a new facility that will be built in Williamsburg County to serve both communities. And when you look at the closure issue, it does get complicated because you can't point to one single thing and say that is why the hospital didn't stay open or that is why it closed. Again, there's a multitude of factors that I spoke to about why these hospitals are struggling. If you look at a little bit older data from the Sheps Center at UNC, it says that not only do roughly 60% of all the closures happen in the Southeast, and in that case, they define it more broadly down kind of Maryland down to Florida and over to Texas, which I know nobody on this phone call defines the Southeast that way. It's a big swath there. But if you define it that way, almost 60% of the hospitals that have closed have been in the Southeast, and almost 80% of the hospitals at risk of closure are in the Southeast. So again, this is a challenge that we share with a lot of our neighboring states in the Southeast, and one that we're looking for some common solutions. So certainly expansion of the Medicaid program in the states is one way that can really help to stem the tide of closures. When you look at small rural hospitals, as Frank alluded to, they're often the first or second largest employer in that county, and they often offer jobs that have health insurance and other benefits that sometimes other employers in those small rural communities aren't able to offer. And while we've really just talked about hospitals so far, every healthcare provider in a rural community benefits when more people are insured and more people have health insurance status, not just the hospital. Every primary care provider, really every provider that bills the patient in some way or bills a third party for payment benefits when more people have the ability to pay. So it really is a rising tide lifts all boats scenario. As Dr. Brown mentioned, research clearly shows that when people do have health insurance coverage, that and ideally a medical home, or what we kind of refer to is one regular healthcare facility or provider that you go to that is your physician or your nurse practitioner or PA, that is your regular source of care. When they have health insurance coverage and when they have a medical home, health outcomes are better and disability is less. So it really, it's hard to dispute the science when you look at the benefits of health insurance coverage. Again, when you look at rural communities, there's a lot that goes into the rationale of why our rural communities struggle as far as healthcare and why our rural hospitals close. But if we could get to the point where we have where lack of insurance or lack of ability to pay is not a barrier in our state, we really will knock down a lot of the challenges that we currently see and a lot of the inequities we see, especially among people of color in rural communities that don't have access to timely care and that end up deferring that care and just makes them sicker. And ultimately, when they do show up at the ER, it's more expensive on the facility, which is more expensive for all of us as the cost gets shifted. So again, I'll stop there. Our office is a resource. We help to get folks enrolled in the ACA through partnerships with a lot of different folks, and really just try and be a resource for rural providers. So I look forward to the question and answer period. Thank you, Ren.
All right, many thanks to all of our presenters. And now we have some time for questions or comments. So the chat box has been activated, and you can put any questions or comments in the chat. Sarah, will you please monitor that and direct questions to who you think the appropriate panelists would be to answer?
Yes, and I'm going to direct this first one to Sue. And I'm wondering if you can tell us about the press conference that's happening tomorrow and the details about that.
I'm so glad you asked. I realized as soon as I put my mute back on, I had forgotten to mention it. Yes, there's going to be a press conference tomorrow morning at 11 a.m. up at the State House on the second floor between the two chambers. Only the Senate's going to be in, but it is going to be the Senate Democratic Caucus is going to be holding this press conference, and they've asked for lots of people who do support Medicaid expansion to show up. It'll be at 11 a.m. It won't last for too long. It shouldn't be that crowded up there since the House is not going to be in and the budget's over, which means that a lot of the people who would be hanging around normally are not going to be up there. But it would be really helpful, because I think the one thing we have to recognize is, and Frank has said it, and Graham has mentioned, we have to talk to our folks back home as to why this is important for all the reasons that we've discussed tonight. But more importantly, we need to make sure they understand that, yes, we can afford to do this. I got a text from one of my colleagues who works at AARP, Teresa Arnold, who said, well, you know, if you just do a back of envelope math out of a $9 billion budget, if it's $90 million a year to do Medicaid expansion, why could we not afford 0.001% of the funds that are spent in our state to help get health care that will help support the rural areas, help support our small businesses, and most importantly, help with the health care outcomes for people in our state who need it the most.
Thanks, Sue. I'd like to send this question to Dr. Adams. When the uninsured seek medical care, it is often after delays and very expensive. These patients are frequently unable to pay their bills. Who pays for the uncompensated care? Does the government share the cost? And how does this compare to the cost of closing the gap?
Hospitals, public hospitals get what is called a disproportionate share fund, and they have access to that because in theory they see a higher percentage of uninsured patients than they would normally, and or they incur costs for that care that can't be reimbursed. What I'll say is our state has done different things throughout the years, maybe in lieu of expansion, that have helped in some ways to increase access to care. Those have been paid for with state dollars. Sue, you'll remember the start of the healthy outcome programs. Those were called HOP, where basically state dollars were given to every hospital in the state to have them better manage frequent flyers to the emergency room. Different programs like that have been put in place to help address some of these issues to varying levels of effectiveness. And I think as far as the cost benefit of what those programs cost versus what we would have benefited by taking the initial expansion dollars, I don't think there's any real math to do there. There would have been a lot more resources available federally to fund those programs and others. Hospitals have charity care, and they have bad debt, and they have a way of kind of shifting costs. But when it's all said and done, it gets shifted to folks that are insured. So all insured patients tend to end up paying more, and the cost of care is just more across the board. But Sue can jump in.
Yeah, I just wanted to also mention, that in our state, people who owe money to many of the hospitals, especially if they're run at all by a municipality or a county or the state, they can have their income tax intercepted. They can have their wages garnished. It's called the GEAR program, and it's often people who can least afford. I mean, many people who wait for their income tax return because that's the only time they may get just a small piece of money that can help pay off some of their debts. And my understanding from the last time we checked, there's a couple $2 billion waiting to be collected from South Carolinians who can least afford to pay it back through the GEAR program. And just in thinking about the $11 billion we left on the table up in DC, that's money that people would have had to support themselves, but instead are struggling to pay off debt because they got sick and now have this debt owed for their medical care.
Well, here's a question that I think is helpful for a lot of people that are new to this discussion, which is, what is the rationale given by South Carolina legislators and our governor for declining to expand Medicaid, back 8 years ago and then now? And I don't know, Sue, if you want to take that first.
Or Frank, would you like to? I don't know that it's a rationale. It's the excuse given is we can't afford to do that. But I beg to differ, and I think that if the math and the calculations and rational thought had been provided, we could have come up with a different conclusion. I just think that unfortunately the politics of the Affordable Care Act and the politics of those in charge collided, and the outcome was people not getting Medicaid coverage when they needed it.
Yeah, Sue's right on target on this. This was, if we were really making business decisions in South Carolina, and everybody always loves to say, gee, the state needs to operate more like a business. Well, this was not a business decision because, if it had been, we would have jumped on it right away. And while they may have said, "Oh, we can't afford it," what happens years down the road when all that 100% goes away and it goes finally down to 90%? We can't afford that. Well, of course we could have, or if they could have just taken it 100% for 3 years and stopped. I mean, they could have done that. That would have been legal. But Sue's right. This was a political decision, and reference what she said when immediately after. We all heard that states would have to make the decision to opt in. There was no analysis. There was no thought process. There was no feedback from the public. It was no, we're not going to do it. So that's where we are. I don't know that that's changed. We're hopeful that it will. Maybe some of these other red states that have taken the initiative of expanded Medicaid, they have been able to afford it and probably do better than affording it. And with this extra bump, that maybe there'll be some business decisions being made in South Carolina. I don't know, but that's the point that everybody has to make to the members of the General Assembly. But I still feel that if it's a political decision, then they need to look over their shoulders of what the federal government does.
Well, and I'll piggyback on that for people who, again, are newer to the conversation than our group that's been looking at this a lot, which is other states are starting the conversation of, oh, we might want to learn more. States that are in the group of 12 that haven't expanded Medicaid. And one of the questions that I think is going to come up a lot is, this incentive is a 2-year incentive, and it's a very significant one for our state. $780 million compared to the about $200 million it would cost to cover people during that time period. And the question is, well, what will happen when the federal government's money for that runs out? How do we counter the argument that then how's the state going to pay for it at that point? And can I send that to Sue?
I'll start it, but I think there may also be Lynn Eichel with your group might also have some had read some literature on that as well. I mean, I think we talked about it a little bit earlier when we discussed and Graham mentioned this with the HOP program. Why should we pay for care at 100% of our state dollars when we can do it at a 90-10 match? And so if in fact we start doing the analysis of how much of our mental health budgets are being paid with 100% state dollars, how much of our care for state prisoners who have to go to the hospital are paid with 100% state dollars, we can, we're going to start doing that analysis and looking at all of that. I think that what we will ultimately discover is that it's not going to be money that the state will have to just suddenly find after the 2 years is over, but we will learn that it's money that we had been spending anyways, and we won't have to spend as much of it. And Lynn, I know that you have some really important information to add. I will let you, I will stop.
Yeah. Okay. Hi. Hello, everyone. I'm Lynn Eichel, and I spent my career in health strategy and policy, and I've been doing a lot of research on Medicaid expansion with my colleagues. And in a study of all of the states that have expanded, there were 8 that really looked at what Sue was talking about. What did they save in fully state-funded programs by substituting federal money? And 6 of the 8 states saved more than 50% of the cost of expanding Medicaid. So instead of 10%, it was 5%. I would also add that in 3 states that looked at what Frank talked about, which is the investment of federal dollars, a good business decision for the state because it grows the economy. The 3 states that really looked at tax revenue increases due to Medicaid expansion found that it covered 1/3 of the cost of expansion. So you've got to look at it all in, what you save in state savings and what you generate in tax revenue when you put more money into the healthcare sector. And those 2 substantially erase the cost of expansion.
Thanks, Lynn. Now, I think there's a couple of questions that address the same issue. One of them is about, have the large healthcare systems in the state taken a stance on expansion? And what about groups like the Hospital Association and the Medical Association, the Nurses Association? And Graham, Dr. Adams, do you have any information about those groups?
I don't about all of them. 1 or 2 that I've talked to, they took some lumps the last few times that they tried to make progress on this at the State House. So I think that they're trying to pick pieces of the rescue plan that is currently available and kind of support those separately, because they think it's an uphill battle for the whole act to be embraced. As for the health systems themselves, I think most of them are very supportive of expansion. I can't speak exactly to what each health system is doing, but I know that they have a lot of staff every day helping to enroll folks in the exchange and into different health insurance programs. So from their perspective, I think they're all pretty supportive. Sue or Frank may have other thoughts.
I would concur with Graham says about some of the associations, but just like legislators need to hear from all of you and from all of us, I think that it's important for the hospitals and the doctors associations for them to hear from us as well. Doing this work and taking lumps, I guess. I represent the low wealth constituency of South Carolina, and that's not a luxury I have to worry about, because my life is easy compared to what the folks that I'm advocating for and I'm working with and on behalf of every day, what they're struggling and going through. So we need to be speaking up, and we need to, we're over the next couple months, we're going to be developing a lot of materials. I know I saw in the chat that folks, what my friends had said, there would be a toolkit. I think they took my words of, as soon as the act was passed, we'd have everything put together. But one of the things we have to do is put together our strategy, start having those discussions. And I think is more importantly than anything is everybody on this Zoom and everyone that is interested in this, they need to start talking to their legislators. And don't feel like you have to be an expert and know every piece of data and every strategic reason why it's important. You only have to, all of us only need to understand is that healthcare and the ability to get quality, affordable healthcare should be available to everybody in South Carolina. And every time we help somebody access that care, we help improve their lives. And when we improve the life of one South Carolinian, we're improving all of our lives. And so we need to start having those messages and going forward. And we will have more information and more data and how we're going to be pursuing this as we go forward. But the most important thing I can suggest to everybody is to be patient. If we weren't patient, we'd never get anything done in this state. But I believe that this is the time that it has to happen. If we haven't learned from what has happened from this pandemic and how important healthcare is and how fragile our state can be without having the coverage for everybody that needs it, then we need to make sure that that lesson is learned by every single legislator. So don't be afraid. We send them to the State House. We need to let them know what we think is important, as well as all of our healthcare providers and our business leaders. We have to get that word out and not be afraid to speak up.
Okay, well, thank you. We are out of time. And I would like to thank our presenters. And now I would like everybody to please turn on your video and give them a virtual round of applause. We planned, as we've mentioned, we plan to send some resources that you can use personally if you want to help push the big rock uphill. As I mentioned, we are recording this program and will send out to all registrants through this Eventbrite system information on how to access it. It will be most helpful if you establish relationships with your state legislators, as Sue has said, so you can express your feelings or feelings on expansion. This is especially true if you are represented by Republicans in our legislature. They are the ones that really can make this happen. The Democrats are, I think, basically on board with this. Communicate also with the media. Newspapers and other media coverage will be key in spreading the word and will be influential in applying heat in Columbia. Already, we have had some excellent coverage in South Carolina by Andy Brack in the city paper and the State House report. And we will be sending you a link to that article if you have not seen it. And also another report, I think on NBC, that was reported on Apple News, reporting that several holdout states are at least beginning to study and consider it. Whether that crack in the dike will lead one state to fall, I don't know. If it does, then that will be helpful in establishing some momentum. But in addition to our panelists, I would like to thank the League of Women Voters, the state and the Charleston chapters and their associates, the lay members of our coalition from the churches, and the many others who have worked hard to make this evening and our efforts possible. I'm also thankful for endorsement of our causes and encouragement or other support from the dozens of other organizations and others who have encouraged our campaign. So now, as Sue says, it's up to each of you. Thank you for attending this forum. Good night, and let's get her done. And if you haven't filled out the brief survey I mentioned earlier, please do so we can stay in touch with you. And I think the link to that ought to be in the chat. And if it's not, we will be sending it out to you in the days ahead.
It's in the chat.
Thank you very much, everybody. And I understand you can just click on the link and then bookmark it, and then you'll have it. So thank everybody, and roll up your sleeves and let's get to work.